Hey there, surgery fans. This video is entitled The Fundamentals of Bariatric Surgery. My name is Edward Schipper. I'm one of the Surgical Education Fellows at the Goodman Surgical Education Center, and this video was prepared with the assistance of Dr. Jim Lau, a bariatric surgeon. Let's review some goals and objectives. The goal of this video is to help learners understand the fundamental principles of bariatric surgery and the basic operations of bariatric surgery. After watching this video, our hope is that the learner will be able to define obesity, describe the physiologic changes associated with obesity, list the comorbidities associated with obesity, list the indications for bariatric surgery, describe the general mechanisms by which bariatric operations induce weight loss, and describe 4 classic bariatric operations: the adjustable gastric band, the biliopancreatic diversion with or without duodenal switch, the Roux-en-Y gastric bypass, and the sleeve gastrectomy. So why should you care about bariatric surgery? For one, obesity is a common problem. It affects approximately 1 in 3 adults in the United States, and you are certain to encounter obesity during your career in medicine. Furthermore, of all the treatment options available for obesity, bariatric surgery works the best. Lifestyle modification with diet and exercise, as well as medical therapy, have all been studied extensively, but none of these interventions has been able to produce long-lasting decreases in the rates of obesity and its associated comorbidities, as well as bariatric surgery has. In fact, depending on the degree of morbidity associated with the obesity, surgical therapy is the standard of care. For all of these reasons, bariatric surgery is becoming increasingly common. Before we continue, we should define obesity in terms of its diagnostic criteria as well as its underlying physiology. Obesity is defined as a body mass index, or BMI, of greater than or equal to 30. Some other important terms to be familiar with. Medically complicated obesity is defined as a BMI of greater than or equal to 35 with an obesity-related comorbidity. Morbid obesity is defined as a BMI of greater than or equal to 40, even in the absence of associated comorbidities. On a physiologic level, what is important to appreciate is that obesity does not just mean more fat. Adipose tissue is metabolically and hormonally active, so having more of this tissue leads to a derangement in the normal metabolic and hormonal milieu, leading to a chronic inflammatory state. These physiologic changes are thought to contribute to the development of the comorbidities associated with obesity. This is important because it is not the obesity itself per se, but these associated conditions that significantly decrease the quality of life and reduce the lifespan of an obese patient. Most of these are cardiac risk factors and thus the life-threatening nature of the disease. Bariatric surgery is such an effective therapy not only because it leads to weight loss, but also because it can help reverse these pathologic physiologic changes. For this reason, the field is often referred to as bariatric and metabolic surgery. So what are the comorbid conditions associated with obesity? The most commonly discussed comorbidities are insulin resistance and diabetes type 2 and cardiovascular disease. These are significant contributors of morbidity and mortality in obese patients. Along those lines, an increasing emphasis is being placed on identifying non-alcoholic fatty liver disease, or NAFLD, which if untreated can progress to non-alcoholic steatohepatitis, or NASH, and ultimately cirrhosis and liver failure, another significant contributor to morbidity and mortality. All this goes to say that we do bariatric surgery to decrease the morbidity and mortality associated with obesity and its physiologically consequent conditions. Obese patients who undergo bariatric surgery live longer with better quality of lives. So how do we decide which obese patients should receive an operation? Assuming the patient has failed a trial of non-operative therapy with diet and exercise or medication, there are 2 primary indications for bariatric surgery. 1, medically complicated obesity, which we just defined as a BMI of greater than or equal to 35 with an obesity-related comorbidity, and 2, morbid obesity, which we just defined as a BMI of greater than or equal to 40. These criteria are somewhat arbitrarily defined and are based on the National Institutes of Health Consensus Conference criteria established in 1991, but they are posited to reflect a burden of obesity severe enough where the risk of morbidity and mortality from the disease outweighs the risk of a bariatric operation. Once the patient and surgeon have decided to pursue the surgical option, the patient should undergo psychological and dietary evaluation to ensure that he has the personal and extrinsic support systems in place to cope with the lifestyle consequences of bariatric surgery prior to undergoing the procedure. So how do these operations work? Historically, the theory underlying surgical intervention for the treatment of obesity has been to induce weight loss by physically limiting the capacity for food intake in the stomach, so-called restrictive operations, or by decreasing the amount of ingested food that is actually absorbed from the gut, so-called malabsorptive operations. Recently, however, surgeons have discovered that bariatric operations have a direct metabolic and hormonal effect that suppress chemical mechanisms of appetite and hunger. This fact helps to explain the long-term success of bariatric procedures compared to non-surgical therapies like diet and exercise, which may reduce net caloric intake but fail to correct problems with appetite and hunger drive. Now that we know the theories underlying bariatric surgery, let's look at some of the different operations out there and see how they work. We will start by reviewing an adjustable gastric band procedure and a biliopancreatic diversion procedure, and then we will continue with the discussion of the Roux-en-Y gastric bypass procedure and the sleeve gastrectomy procedure. The adjustable gastric band procedure, often referred to as a lap band because it is placed laparoscopically, demonstrates a primarily restrictive procedure. In this operation, a band is placed around the proximal part of the stomach to create a small pouch between the GE junction and the band, effectively limiting the reservoir capacity of the stomach. The band can be inflated or deflated with needle fluid injection into a port that is placed subcutaneously at the time of operation. The operation works by restricting the amount of food that can be tolerated by the patient. The smaller the pouch, the quicker the gastric reservoir fills, causing satiety, and thus the patient will no longer feel compelled to eat. Once the ingested food does traverse the narrowing created by the band and into the distal stomach, however, the remaining gastrointestinal anatomy is otherwise normal, and so the ingested food is absorbed as it would be in a normal individual. In other words, there is no malabsorptive component to the adjustable gastric band procedure. In contrast, the biliopancreatic diversion represents a primarily malabsorptive surgical option. First, let us take a moment to understand the mechanisms through which malabsorptive procedures work. Recall that food cannot be absorbed by the small intestines unless it is broken down into component forms and solubilized by digestive enzymes and bile made by the pancreas and liver. Anatomically, these biliopancreatic digestive catalysts are secreted into the duodenum, the first stop for ingested food after passing through the stomach and before passing along the entire remaining absorptive capacity of the small intestine. Malabsorptive procedures work by diverting undigested food in the stomach away from the duodenum and the biliopancreatic secretions and into more distal bowel devoid of these digestive substrates. Another way to say this is that the biliopancreatic portion of the gut is bypassed. In the absence of these biliopancreatic secretions, a bolus of ingested food, along with all of the associated calories and fat that contribute to weight gain, cannot be absorbed by the small intestine, and so it simply travels through the entire length of the GI tract unaltered and passes in the stool. Of course, essential nutrients go unabsorbed as well, predisposing the patient to fat-soluble vitamin deficiencies and other nutritional insufficiencies. Appropriate nutritional supplementation with vitamins is an important component of postoperative therapy in these patients. Now let's review the steps of a pancreatic diversion operation and see how it causes malabsorption. The first major step in the operation is to divide the stomach, run the bowel all the way down to the terminal ileum, and then divide the terminal ileum. Importantly, the long segment of bowel between these two divisions includes the duodenum, where all of the biliopancreatic digestive juices are secreted. Accordingly, this segment is known as the biliopancreatic limb, or the BP limb. The distal ileum is then mobilized and brought up to the stomach to create a gastroileal anastomosis. At this point, any ingested food leaving the stomach will pass directly into a short segment of terminal ileum, effectively circumventing most of the absorptive capacity of the small intestine and without any contact with biliopancreatic secretions. In order to ensure that some life-sustaining nutrients in a food bolus are absorbed, the distal end of the biliopancreatic limb is anastomosed to the terminal ileum approximately 100 centimeters proximal to the ileocecal junction. The portion of bowel distal to this ileo-ileal anastomosis is called the common channel because it is the final common pathway for contents from both the proximal stomach as well as the biliopancreatic limb. Connecting the small intestine directly to the stomach without any gatekeeper function of the pylorus can cause problems. In one sense, the pylorus keeps things from getting out of the stomach, functioning to ration the amount of ingested food that is dispensed to the small intestine at any one time. When this function is lost, as happens with the gastroileal anastomosis and the biliopancreatic diversion, the stomach may present large boluses of food to the small intestine shortly after oral intake. This food then acts as a large osmotic load that can cause bloating, cramping, and diarrhea, a condition known as gastric dumping syndrome or rapid gastric emptying syndrome. The pylorus also keeps things from getting into the stomach. When this function is lost, bile from the intestines can reflux into the stomach and irritate the gastric mucosa, explaining why patients with a biliopancreatic diversion who have a gastroileal anastomosis can get ulcers at the anastomotic margin, known as marginal ulcers. To prevent these problems with biliopancreatic diversion, surgeons have developed a technique known as the duodenal switch to preserve pyloric function. In this modification of biliopancreatic diversion, the first part of the duodenum is divided rather than the stomach. The lateral two-thirds of the stomach is removed to decrease its storage capacity, adding a restrictive component to the procedure. The division of the distal ileum is completed as before. With this modification, the biliopancreatic limb contains no portion of the stomach. The distal ileum is then reanastomosed with the proximal portion of the duodenum rather than directly to the stomach, allowing the pylorus to continue functioning as the gatekeeper between stomach and small intestine and preventing problems with gastric dumping as well as bile reflux and marginal ulcers. The rest of the operation is completed as described previously. In the literature, this procedure is known as biliopancreatic diversion with duodenal switch, or sometimes simply as a duodenal switch. Now that we have reviewed the adjustable gastric band procedure and the biliopancreatic diversion with duodenal switch, we will discuss two other operations in the bariatric surgery armamentarium, the Roux-en-Y gastric bypass and the sleeve gastrectomy. These two operations make up the vast majority of bariatric operations performed in the United States today. There are more sleeve gastrectomies being done now than any other operation. The Roux-en-Y gastric bypass shares several features with the biliopancreatic diversion. Like the biliopancreatic diversion, the stomach is divided, but in the case of the Roux-en-Y gastric bypass, the stomach is divided relatively superiorly to create a very small proximal gastric pouch. Here, we see the restrictive component of the operation. Also, like in biliopancreatic diversion, an area of small bowel distal to the stomach is divided, but in the case of the Roux-en-Y gastric bypass, this location is in the jejunum. As with biliopancreatic diversion, the isolated limb of bowel between the distal stomach, known as the gastric remnant, and the proximal jejunum contains the duodenum and its associated biliopancreatic secretions, and so it is called the biliopancreatic limb. The distal jejunum is mobilized and anastomosed to the proximal gastric pouch. Again, the functional lack of a pylorus between stomach and small bowel opens the door for the possibility of gastric dumping syndrome and bile reflux and marginal ulcers. The distal end of jejunum of the biliopancreatic limb is then reanastomosed to another area of jejunum downstream, creating a jejunostomy. The Roux-en-Y gastric bypass is so named because the anastomosis of the biliopancreatic limb to the jejunum creates a physical configuration of bowel that looks like the letter Y. In this arrangement, the jejunostomy is located at the intersection of the Y. The shorter biliopancreatic limb feeds into the longer stem of the Y, represented by the length of small bowel between the proximal gastric pouch and the ileocecal valve, and so the BP limb can also be referred to as the Y limb. The jejunostomy site also serves as a landmark that divides the stem of the Y into two parts. The part that is proximal to the jejunostomy is called the Roux limb. The part that is distal to the jejunostomy is called the common channel, again suggesting a final common pathway for contents from both the proximal gastric pouch and the BP limb. It is a bypass in the sense that a food bolus travels from the proximal gastric pouch directly into a limb of jejunum, bypassing the normal path of food that would otherwise include a trip through the duodenum. This explains the malabsorptive component of the procedure. This complex rearrangement of the intestinal anatomy has important clinical implications. Mobilizing the small intestine so that it can be brought up to the stomach requires dividing not only the bowel itself, but also its associated mesentery. These resultant mesenteric defects, if not repaired intraoperatively, can create potential spaces where small intestine can herniate and cause obstruction. They are called internal hernias because all herniated contents remain inside the peritoneal cavity. Internal hernia is a special problem for patients who have undergone bariatric surgery, and the surgeon managing the bariatric patient who presents with a small bowel obstruction should have a high index of suspicion for this problem that requires immediate surgical repair. Bringing the small intestine to stomach for an anastomosis is also difficult because of the transverse mesocolon that physically separates the two structures. The small intestine can be brought up anterior to the transverse colon to circumvent the transverse mesocolon, the so-called anticolic approach, but this requires a sufficient length of bowel to be mobilized, which may not always be possible. Alternatively, a defect can be surgically created through the transverse mesocolon to advance the small intestine posterior to the colon up to the stomach, the so-called retrocolic approach. A retrocolic approach adds another mesenteric defect and another opportunity for an internal hernia to occur to the procedure, although it should be noted that internal hernias can still occur with an anticolic approach because small bowel and its mesentery are still being divided. The last bariatric operation we will discuss is the sleeve gastrectomy. The sleeve gastrectomy induces weight loss through a restrictive effect as well as a metabolic effect. In this operation, the greater curvature of the stomach is devascularized and then a sleeve of greater curvature is resected, leaving a small tube of stomach along the lesser curvature and decreasing the stomach's reservoir capacity. The sleeve of stomach along the greater curvature that is removed includes a significant amount of fundus, the location where ghrelin, a hormone that centrally stimulates appetite, is produced. Removing this source of ghrelin-producing cells and therefore decreasing the patient's appetite adds a significant metabolic component to the sleeve gastrectomy. As the rest of the gastrointestinal tract is left intact, there is no malabsorptive component to this procedure. And that concludes the fundamentals of bariatric surgery.